Good morning, everyone. Today we are going to discuss about volvulus and intussusception. Last week we did discuss about intestinal obstruction and what are the causes of intestinal obstruction. It was a short discussion. And in the next few classes, I will be discussing the more important causes of intestinal obstruction, or most of the causes which are pertinent to the examination. I have seen in the last few examinations a lot of questions related to volvulus and intussusception were asked by the examiners, and most of them were answered correctly. But I just felt that some of you are not very clear about the basics. Now, I will not go into a very in-depth discussion today. In 1 hour, it's not easy to discuss everything. But we'll just have a discussion about the more superficial part of the volvulus and intussusception. So let's start with volvulus. Volvulus, like most of the medical terms, it has also originated from the Latin word volvere, which means to twist. What happens here? A twisting. There is a twisting or axial rotation of a portion of the bowel about its axis. The simple thing is, if you remember the sigmoid colon, it's something like this, right? What happens if this is the axis of the mesocolon, and if there is some twisting around this axis, this is called volvulus. Now, normally this does not happen. A lot of our intestine, the small intestine has demesentery. The sigmoid colon has its own sigmoid mesocolon. The transverse colon has another transverse mesocolon, but rarely there is any rotation around their mesentery. And most of the people are very okay with whatever they have, but sometimes a twisting or rotation around the axis may take place, especially with patients who has a particular features, which we will discuss very shortly. For the time being, just remember this. There's twisting or axial rotation of a portion of the bowel around its axis. If this is the axis, the twisting will take place, maybe in the anti-clockwise direction or maybe in the clockwise direction. Most of the time, it is in the anti-clockwise direction. Now, you can very clearly understand that if there is twisting, there will be obstruction, right? The lumen will get narrow. So when there is 180-degree twisting, there is usually luminal obstruction. Luminal obstruction means the intestinal content cannot go through, but the blood supply is okay. But if there is a 360-degree rotation, then the more danger comes. Then there will be a vascular obstruction, and followed by ischemia and strangulation will take place. So that's dangerous. In fact, both are dangerous, but whenever there is more than 360 degrees rotation and vascular obstruction has taken place, it means immediate management, and ideally it should be surgical management. It's an emergency procedure. But in this just luminal obstruction, which you will see many elderly gentlemen will come to you with luminal obstruction due to volvulus or sigmoid colon usually, and you will check for whether there is a vascular obstruction. If there is no vascular obstruction, only luminal obstruction, then initially we go for conservative therapy. But if you see the patient is having tachycardia, increased pulse, pain, distension, and other features, then we will have to convert to surgery. So, in fact, volvulus can happen almost any part of the intestine with a mesentery, but the commonest site is the sigmoid colon. There can be volvulus of the transverse colon, cecum, and splenic flexure as well. Actually, but I have never seen in cecal volvulus or the transverse colon or the sigmoid flexure volvulus. Most of the volvulus I have seen in my life are the sigmoid volvulus. So this is the commonest. And today I will mostly discuss on the sigmoid volvulus because this is actually, we are taking an undergraduate class. This is mostly most of you guys who are at the undergraduate level. We will discuss very as simplified as possible so that there's enough information for you to pass the final professional examination. Okay. There is a statistics that more males are suffering from this than the females, but recently I have seen one female patient having volvulus. So these statistics are not something that are definite, but more common with patients who are more than 50 years. That's correct. I have seen most of my patients were above 50 years. It's very rare in younger generations. I will come to those why this thing happens, because one of the predisposing factors for volvulus is loaded colon. That is, if this is the colon, it should be loaded with usually contents, intestinal contents, mostly fecal material, which are more common in the elderly. And what happens in the elderly, the muscles are very weak. The intestinal muscles, smooth muscles are weak, and they cannot push the intestinal contents forward. And as a result, there's more chance of having loaded colons. And the loaded colons are another one important factors of intestinal obstruction in the form of volvulus. Common in third and fourth, these are not very important. Psychiatric illness, yes, common in case of psychiatric illness who are not very well taken care of. So that's quite common in case of psychiatric patients. You'll see those, a lot of those in psychiatric institutions. Debilitated, institutionalized patients, underlying neurologic disease. What happens in case of neurologic disease? Again, the peristalsis, which is under the command of the both has both neurological parts and muscular parts. So what happens is, if the patient has some neurological disease, there is certainly a chance that the peristalsis will become weak or sometimes absent, as a result which may result into volvulus. So other problems like Crohn's disease, Chagas disease, these are also predisposing factors. In case of children, Hirschsprung disease, megacolon, and stenosis. Not very important, but it's worth knowing these things. Okay, this is very important. Volvulus is usually primary or secondary. Primary, commonest cause of the primary volvulus are congenital intestinal malrotation. Congenital intestinal malrotation, or volvulus neonatorum. Volvulus neonatorum. It's written over here. Volvulus neonatorum. Patients usually have abnormal mesenteric attachments, congenital bands. So this is actually inborn problem. Whenever the person was born, the person by birth were having these problems. What may be some of those problems? We will discuss this in greater details, but there may be a long mesentery, or maybe there may be congenital bands, very important, congenital bands. For example, if this is the sigmoid colon, let's say if this is the sigmoid colon, and this is the sigmoid mesentery, there may be a congenital band over here attaching itself to the anterior abdominal wall. As a result, there is a greater chance of intestinal rotation around this band. So these are usually primary causes. Then comes secondary, which is more common, and rotation around an acquired adhesion. When does this happen? Maybe the patient had some sort of surgery, and as a result, a band or some sorts of as the adhesions has been formed in the abdomen. This is acquired, to be honest. This is acquired. And then there are compound volvulus. For example, well, not only the colon is involved, together with the colon, the ileum is also involved. For example, ileosigmoid knotting. This is called when two parts of the bowel are are knotted around each other or twisted around each other. It becomes a compound volvulus. I have seen two compound volvuli in my life, and they were very actually quite bad. And in both cases, they were gangrene. And but fortunately, in both times, the patient survived. So very important is you must treat the patient as early as possible. This is some of the anatomy. You don't have to learn a lot of it, but the most important part, for example, if this is the sigmoid volvulus, if there is a rotation, usually in the anti-clockwise direction, what happens? These blood supplies, these blood vessels, when there's 360-degree torsion, this blood supply get hampered, get compressed, ischemia occurs, and if immediate management is not done, then there's a chance of gangrene of the bowel. And once there is gangrene of the bowel, the patient is in morbid condition. Usually this produces a lot of toxic chemicals, cytokines, and which are deadly for the patient. So it's very important that if possible, treat the patient before gangrene has taken place. Pathophysiology, these are actually quite simple. What happens most of the time, there is edema because the blood supply is hampered. The blood supply is hampered. What happens most of the times, the venous supply is cut off before the arterial supply, and as a result, there is a lot of edema. And edema actually what it exacerbates the pressure on the blood vessels, it exacerbates the pressure on the intestine, and as a result both uh, vascular and luminal obstruction takes place. And most of the time, to be honest, both twisting can be both clockwise and anti-clockwise, but anti-clockwise is common. Anti-clockwise is more common, and the twisting can vary from 90 degrees to 360 degrees. If it is 180 degrees, it causes luminal obstruction. If it is 360 degrees, it causes vascular obstruction. There will be a closed loop obstruction, as you can understand. If the sigmoid loop is twisted, if the sigmoid colon is twisted like this, then there will be a closed loop obstruction. There will be a closed loop obstruction. From here to here, there will be a closed loop obstruction. And this causes, what happens is there are a lot of gas producing bacteria, and they will initially produce gas. There will be edema. There will be there's a chance of bacterial putrefaction. So what happens after that, there may be chance of bacterial translocation. Septicemia will take place. If there's gangrene, then what happens is a lot of cytokines are produced, toxic chemicals, oxygen free radicals are produced, and patient will go into septicemic shock. Septicemic shock. Definitely, also as because there's intestinal obstruction, there may be hypovolemic shock as well. There may be hypovolemic shock as well. So all these things has to be treated as early as possible. Translocation of bacteria, we have just discussed, it causes septicemic shock, peritonitis, septic shock. And once septic shock has started, it's very difficult to reverse the patient. It usually ends up into death of the patient. So that's why what I'm saying is the patient has to be treated as early as possible. Okay, then the pathophysiology, and again, just we have already discussed all those things. 180 degrees rotation causes luminal obstruction. 360-degree rotation causes strangulation or vascular obstruction. Now, this is very important. What are some of the predisposing factors for volvulus? For example, we all have our mesocolons, right? Mesocolons, mesentery, the transverse mesocolon, the sigmoid mesocolon, the mesentery, but we are not all having this sort of problems. We are not having volvulus. So what is the real cause behind it? Number one, there is narrow attachment of the pelvic colon. For example, if there is a wide attachment of the colon or the intestine, wide attachment, this is always good. There's less chance rather than having a very narrow attachment. For example, if the attachment is like this, there is a greater chance of volvulus or twisting. Long pelvic mesocolon. This is again very important. If the pelvic colon is something like this, then again there is a greater chance of volvulus. Overloaded pelvic colon, which we have just discussed, but this is very common in patients of the elderly. There's impacted stool inside the colon. Because of the weakness of the colon, as a result, there's a chance of volvulus in the elderly. Then bends and adhesions, congenital. In case of congenital, the primary volvulus. In case of acquired, the secondary volvulus takes place. Clinical features, as usual, the clinical features. The first thing is there is intestinal obstruction, right? So there will be pain, abdominal pain, which is colicky in nature, right? There will be vomiting. There will be abdominal distension and constipation. These are the few of the more important things. Distension is particularly prominent in case of volvulus. You'll see huge distension of the abdomen, which will, it will be very apparent. There may be emptiness of the left iliac fossa. It's because the sigmoid colon, which was previously there, is not present, but it's not a very important finding, as because of the distension, it's sometimes very difficult to elicit this thing. So it's not very important. You don't have to learn this. But distension, tenderness on palpation, these are very important findings. Tympanic on percussion. Now, what are the red flag signs? The red flag signs are severe tenderness, rebound tenderness, guarding rigidity, fever, tachycardia, hypotension. This points towards a gangrenous segment. This is very, very important. This is very important. On digital rectal examination, you may get an empty rectum. So if you do an X-ray, plain X-ray of abdomen, you'll get huge pneumatic tire-like gas shadow. Tire-like shadow. This is the one. In case of sigmoid volvulus, something like this, whose curvature is towards the left iliac fossa. This is a very typical sign or radiological feature of sigmoid volvulus, huge pneumatic tire-like gas shadow. You can see the bowel is very distended. You also may get other features of intestinal obstruction, like air fluid levels, multiple air fluid levels. But usually, this is the pneumatic tire-like shadow. This is something which tells us that this is sigmoid volvulus. Similarly, if the patient had a thecal volvulus, the patient the would have been something like this, just in the opposite direction. Again, another feature, another picture of the sigmoid volvulus. So what happens? The patient comes to you, you do some investigations, you do an X-ray, and you find out the patient is having sigmoid volvulus. So immediately do you go for surgery, or would you go for conservative treatment? So this algorithm would help you understand that this make your plan. For example, if the patient is having bowel ischemia, if there are features of bowel ischemia, for example, the patient is having tachycardia, increasing severe abdominal tenderness, rebound tenderness, pain, patient is deteriorating, blood pressure is falling, then it's a sign of bowel ischemia, which we have just discussed a few slides before. Severe tenderness, rebound tenderness, guarding rigidity, fever, tachycardia, hypotension. If features are like this, then we must go for operating theater, the OT, for immediate laparotomy. Remember, you go for laparotomy, not laparoscopy. Laparotomy. But if there are no signs of bowel ischemia, only abdominal distension is present, then conservative treatment would be the best choice of management. Initially, we go for endoscopic detortion. We use the colonoscope to untwist the colon. If it is successful, that's great. Then elective resection in the same admission. What happens is slightly different. There's slight difference in young and old patients. If it's a young patient, definitely we must go for resection and anastomosis once the patient went endoscopic detortion is successful. It must be done in an elective setting. But what is important is in case of elderly patient, we don't usually, if the patient, if detortion is successful, then conservative therapy treatment, bowel softener, these are given, because uh, elderly patients, large surgery can be risky, but younger patients always definitive management is important. So what happens if the endoscopic detortion is unsuccessful? If it is unsuccessful, then again go for operation. You do a laparotomy, you check the intestine, whether it is viable or not, whether it is gangrenous or not. How do you understand it's viable? For example, if in case of viable, if it is viable, they're shiny, they're healthy looking. If you prick it with a needle, there will be bleeding, there will be visible peristalsis present. All these features are absent, then usually the intestine is non-viable. If features are absent, then you can use a hot mop um, to see if the blood supply comes back. But before that, remember, in the operating table, you first again detort, you untwist the intestine and then do all these things. The first thing is what you should do is untwist the colon. But if you think that it's straightforward, if you think that it is gangrenous, then you don't have to untwist it, and then you go for resection. This is actually important, not at undergrad level, it's not very necessary, but at postgrad level, it's important to understand that if it is if you're sure that it's gangrenous, and then don't untwist it, because there is a chance that the toxic materials will go into the other parts of the intestine. It's better to go for resection and anastomosis without untwisting it. But if there's a confusion whether it's viable or not, then untwist it, check for its viability, and then go for the surgery. So as usual, we again must go for resuscitation. If the patient is in shock, must resuscitate the patient. We give intravenous fluid. What are the important ones? We give normal saline or hard salt, Hartmann solution. These are the two things that we initially will give. Intravenous antibiotics. Usually we give ceftriaxone and metronidazole. Ceftriaxone and metro. Must give a nasogastric tube to decompress the intestine, a urinary catheter to monitor the input-output, to monitor whether we are giving enough fluids or hydration is taken, when we are correcting the hydration status of the patient. Definitely a monitoring should be done. What are the things we need to monitor? The vital signs. The vital signs. Pulse, blood pressure, temperature, sorry, temperature, and then respiratory rate. These are the things that we are monitoring. The urine output is something which has to be monitored. Ask the patient whether the patient is feeling better, whether the pain is decreasing or not. Then supplemental oxygen and transfusion is needed. These are not very important, but these are the things that's very important. And also remember, TED stockings are used. Why? Because there is chance of deep vein thrombosis, DVT. What do you mean by TED? Thromboembolic deterrent stocking. It's not important. You don't have to learn all this things, but if you know this, is good. Thromboembolic deterrent stocking. Why these are needed? For deep vein thrombosis. But usually in Bangladesh, these are actually rare, so you don't have to talk about it. But keep it in your mind that you may have to do this. It's always a very good practice, because many of the good hospitals actually do this, especially in the elderly patients. Supplemental oxygen transfusion if needed. Non-operative endoscopic detortion, we have already discussed. Patient must be stable. Patient must be stable. If the patient is unstable, then we must go for operating theater. There's no features of gangrene. You can use a colonoscope or flexible sigmoidoscope or the rigid sigmoidoscope. Anything can be used. Rectal tube, once detortion has taken place, a rectal tube can be placed over there. Then do an x-ray. After detortion, place a rectal tube, then do an abdominal x-ray to check whether detortion has taken place. And definitely patient must be observed carefully. So this is a picture of how detortion is taking place. This is an endoscopic detortion. Operative. It's very important. A definitive procedure. A lot of procedures are being done, but the definitive procedure is actually resection and anastomosis. Resection, anastomosis can be done or sometimes not done, but resection is something that must be done of the twisted segment. So we give patient in supine. These are not very important. You don't have to know all these things. So this is something which we have done. What have we done here? So for example, if this is the colon, this is the transverse colon, and let's say this is the sigmoid colon that has twisted itself, right? So what are we trying to do? And we first check for the viability, and if we find out that this has actually is gangrenous or irreversible damage has taken place, so we resect it. We resect it. And after resection, what do? This part is not there. The proximal colon is brought out as a colostomy, and the distal colon or the rectum is closed. So this is called Hartmann's procedure. What are we doing? We are resecting the diseased part, number one. Number two, there is a proximal end colostomy. And what happens to distal part of the rectum? We are closing it, right? We usually attach a non-absorbable suture material over here because, for example, in the future, we attach a non-absorbable suture material with the rectum, with the closed rectum, so that in the future, when we will try to reverse the we will try to re-anastomose this part with this part, then we need to find it. Believe me, it's very, very difficult to reverse a Hartmann's procedure, and it's not done very commonly. If it's done, if absolutely it's anastomosis is contraindicated, then we do it. But other than that, in my preference is do a primary anastomosis and then do a ileostomy. I think that would be a better procedure. If you think you have stabilized the patient, but if it's an unstable patient, then certainly there is no other option other than Hartmann's procedure, which is actually a life-saving procedure for this patient. So this is what it looks like. The part of the sigmoid colon is brought out as an end colostomy. The distal rectum is closed and left into the pelvis, and the diseased part is removed. This is what it looks like in case of volvulus. This part of the colon is quite healthy. It's a much better outcome if the colon looks like this, but sometimes it's gangrenous and outcomes are usually not very good. So there are some other procedures like Paul Mikulit's procedure, mesosigmoidoplasty, and the detorsion sigmoidoplasty, laparoscopy. Paul Mikulit's procedure is not very difficult. What happens is, for example, if this is the abdominal wall, and if this is the, let's say this is the sigmoid colon, and this is the part that has twisted itself. So we remove this part, and what is left with is, if this is the abdominal wall, the two parts of the colon are left as a double barrel. So this is called Paul Mikulit's procedure. Mesosigmoidoplasty, I have actually a picture of it. This is not very important, you don't have to learn it, but remember that we just cutting it in a longitudinal direction and then stitching it in the transverse direction, which shortens the mesentery or widens the mesentery. The length is decreased, but the width is increased. There's usually less chance of torsion. This is not done. Paul Mikulit's procedure sometimes is done, but most of the times Hartmann's procedure is done. So this is a major sigmoid volvulus is a major cause of intestinal obstruction, especially in the elderly. Resuscitation, endoscopic detortion, and these are the things what we do. And with primary anastomosis can be done, or Hartmann's procedure are the mainstay of treatment. Okay, then we will go into intussusception. So what is intussusception? Telescoping invagination of an intestinal segment into the lumen of a proximal segment. What it looks like? For example, I think it should not be the proximal, it should be distal. It should be a distal segment. For example, let me just show you. It's, for example, if this is the colon, let's say, if this is the distal segment and this is the proximal segment. So what happens is the proximal segment has entered into the distal segment. Telescoping, invagination has taken place. This is called the lid point. If there is some pathology over here, for example, a polyp may be over here, this part is called the intussusceptum, the part which is into the which is the inner part of the intussusception, and the outer part is called the intussusception. We will discuss this. So this is called an intussusception. So for example, in this case there is no lid point. In this case there is a lid point. Lid point means there is a pathology. For example, a polyp. Usually there is a polyp present. Something, lid points are usually present, but they can also be absent at times. So what are the etiologies? Children, actually it happens commonly in children, not in adults. Spontaneous, that means without any lid point. What happens? Mucosal edema, lymphoid hyperplasia after viral gastroenteritis. You know, there are Peyer's patches in the small intestine, the Peyer's patches. The Peyer's patches. What happens is when the Peyer's patches in the terminal ileum becomes hyperplastic, actually sort of like they act like a lid point, to be honest, but there's no pathological lid point other than this. What happens in when there's Peyer's patches which are hyperplastic, this may result into invagination of the proximal part into the distal part. What are the examples of lid point? Michel's diverticulum is a very common finding. Polyps are also common. I think if you remember only these two, that's good enough. In case of adults, celiac disease, scleroderma, Whipple's disease, many things can happen. But yes, tumor, both benign and malignant, and polyps. These are the commonest lid points in case of adults. Clinical features. In children, there is always crampy abdominal pain. These are very similar. Pain, abdominal distension, vomiting, constipation. These are usually common, but in children, there is usually red currant jelly stool. Red currant is one type of fruit, so it looks like red currant jelly. I'll show you. Abdominal mass. There may be an abdominal mass present. In adults, similar features may be present as well. In children, ileocolic, ileoileal, colocolic, and different types. In adults, similar things can happen as well. But in the children, the commonest one is ileocolic. This is the commonest. So this is called the red currant jelly stool. These are the red currants. So red currant jelly stool. Clinical features, these are not very important. What is important here is if there is features of intussusception, we can go for hydrostatic reduction or pneumatic reduction, and they must be done either under sonologic or fluoroscopic guidance. This is important. We do some investigations again on abdominal examination or abdominal x-ray. You will get dilated gas-filled intestines with multiple fluid levels, but ultrasound is the most important investigation in case of intussusception, where you get donut sign or target sign. What do you mean by this? For example, what happens if you remember the picture? This is actually what an intussusception looks like. So if you do a cross section of it, you'll see that it actually looks like something like this. So it looks like a donut. And if you take all the layers in consideration, there is actually 4 layers, right? So it actually looked like a target sign. You remember the circular structures that we go for target practicing? So it looks like a target sign. So donut sign or target sign. Pseudokidney. What happens is if you take a longitudinal picture of it, we have taken a transverse picture. If you take a longitudinal picture of it, it looks like a kidney or a pseudokidney sign is present. Bowel enema has both diagnostic and therapeutic effects. Now, one must remember that if there is features of perforation or gangrene, bowel enema should never be done. It's very important that if you don't do that. That if the patient is stable, then you can go for bowel enema, which has both therapeutic and diagnostic advantages. This is a sign of dance. What happens here is the right iliac fossa becomes empty, because what happens is the intestine has invaginated and has been pulled into the proximal part somewhere around here. So this part becomes empty. It looks like as if that part of the abdomen is empty. So this is called sign of dance. Meniscus sign. There's sometimes in the colon there's crescentic gas shadow, something like this. This is called the meniscus sign, which is not very important. But the target sign is very important. The sign of dance is very important. These are written in your book, so you have to learn those. Here, in the ultrasound, if you do a transverse section, you'll see it looks something like a target or a donut. Enemas, there may be pneumatic. That means air enema. This is quite safe. But sometimes, but remember, none of the enemas should be tried if there is signs of perforation or gangrene. Must remember this. Hydrostatic, in this case, normal saline is used. Barium can also be used, but never use it if there is chance of perforation. These are not very important. CT scan can be done. Again, if you do a CT scan, you will see a target sign over here, something like that, or a donut sign. So again, how will you manage such a patient? Always conservative treatment. If the patient is unstable, it must be resuscitated. First must be resuscitated. We give an NG tube, an intravenous line is initiated. We give IV fluids like baby saline in case if there's a child. IV antibiotics must be given because there's always a chance of perforation. There's always a chance of severe infection or translocation of bacteria. So must give antibiotics. Radiology has both therapeutic and diagnostic advantages. So air enema or hygrostatic enema or barium enema can be given, must be. The choice of enema is usually left to the radiologist. But as I've already discussed, many now favor air enema, which is actually the safest. When we go for laparotomy, if there is sign of peritonitis, perforation, prolonged history, pathological lead points, failed enema. Pathological lead points means there is a Michel's diverticulum or a polyp. So these things has to be removed, right? So go for a laparotomy and remove these things. So always if these features and the conservative reduction in the form of air enema or the hydrostatic enema or the barium enema has failed and the patient's clinical features are worsening, then go for surgical treatment. In case of surgical treatment, it's usually resection and anastomosis is done. These are not very important. Pneumatic techniques. Just remember this. What happens if you do a pneumatic technique, and if you use a contrast material, if you think the patient, if the intussusception has been reduced, then there will be free flow of contrast materials or air into the small bowel. That's how you understand that the reduction has taken place, and definitely relief of symptoms. So what happens is, if you find out that the particular part of the there is an intussusception, so you do a resection followed by anastomosis. But what is important is you must take the lead point. For example, if you remember the Michel's diverticulum, it is something like this, a diverticulum in the colon. So this can be a lead point. So excision, or it's better to excise the whole part because there's always a chance of gangrene. So it's better to excise the whole part and then do a reanastomosis of it. So another few things that I would like to discuss today is commonly intussusception takes place around the age of 2 months to 2 years. This is very important. This happens in the younger people, younger, very young children at the age from the age of 2 months to 2 years, when the weaning takes place. That means when they are converted from breastfeeding to more are taking other types of foods. That's when this can happen. There's always, remember, there may be a lead point present, there may not be a lead point present, but if usually if someone is having intussusception and who is greater than 2 years, then that's usually due to a pathological lead point, maybe in the form of mucus diverticulum or a polyp. So remember this, there is usually the lead points. What are the lead points over here? In case of children, mucus diverticulum and polyp, these are the more important ones. In case of elderly population, tumor, maybe benign or malignant, and polyps. These are the important things. And we do not immediately go into surgery. We first try to reduce it by enemas, maybe pneumatic, maybe hydrostatic, maybe barium enema. CT scan sometimes can be done because it's very, but if the patient is unstable, it's usually not done. Ultrasound is the mainstay of my main investigation that is done. Again, if the patient comes to you with such features, you think it's an intussusception, first try to stabilize the patient with conservative therapy, with conservative treatments, an nasogastric tube and intravenous fluids, intravenous antibiotics, painkillers may be given, antispasmodics may be given, catheterize the patient and monitor the patient carefully. And if you think the patient is improving, especially after the conservative reduction can be done successfully in the form of hydrostatic or air enema or barium enema, then you go, then you do the definitive treatment, maybe in an elective setting. Especially surgery is a must if you think there is a pathological lead point present. It's very important. Peritonitis, perforation, these are also important indications of laparotomy. Failed enema. Usually the patient, if you can do an early treatment, in case of a young children, usual results are very good. Most of the times, but in elderly patients, usually outcome can be bad because most of the times I have seen intussusception due to malignancy, and usually outcomes are very bad. In case of children, it's usually ileocolic. But in case of elderly or the adult, it's usually colocolic. And most of the times it's due to a malignancy. It's conservatively first treated in a non-operative fashion with reduction, with radiological reduction. If fails, then go for surgery. How do you understand reduction has taken place? There is usually free flow of contrast material into the small bowel and you'll be immediate relief of symptoms. Okay, thank you so much for your time. Tomorrow, next week, we will probably discuss in other causes of intestinal obstruction. It's worth giving some time in these topics because these are very, very important and always are asked in the final professional examination. So if you guys have any questions, feel free to ask. And thank you so much.